you, Rupam. Gosh, something to live up to. Okay, so I'd like to thank Savita and the SACC for inviting me to talk at this meeting. I'm very honored. These are my disclosures. So I'll start with the Black Swan. This was an editorial by Nigel Harris 30 years ago when APS was getting onto the medical map. And a member of the audience told him when he was presenting a case, "You are showing us a black swan." Of course, they were a little out of date because by then there were black swans. And subsequently the term became hijacked by a financial expert with a completely different meaning. But anyway, I think these comments from Nigel were really quite prescient all those years ago. So antiphospholipid syndrome is characterized by thrombosis, which is venous or arterial, affecting any vessels in the body, or microvascular thrombosis, this was biopsy proven, or obstetric morbidity in association with persistent antiphospholipid antibodies. These are data from the Europhospholipid project run by Richard Cervera, and you can see that deep vein thrombosis and stroke and TIAs account for some 70% of the patients have those manifestations, and fetal manifestations are also quite common. So if we talk at this stage about how common is this condition, it clearly isn't a black swan, but in the USA it's listed as a rare disease, which means that there should be less than 200,000 patients, which if you set against the US population of about 326 million, that's quite few patients, but still quite a lot numerically. The APS has fallen off the European Union list of rare diseases, except for CAPS and neonatal APS. So if we see a patient with APS, mainly we see them with DVT or stroke. And based on systematic reviews, about 10% of VTE patients have got APS, and about 14% of stroke patients have got APS. And if you set that against the 10 million per year of VTE patients and the 17 million per year, this is worldwide, of the stroke patients, there should be an awful lot of patients, but there aren't. So which is it, a semi-black swan or a very common disease? So the key to managing APS with anticoagulation is to find the patients. So what tests should we do? This is data from a study that we did. We started off with 193 patients and then looked at the ones who fulfilled the Sapporo/Sydney criteria, and of them, 100 fulfilled the full criteria, and then the remaining 26 were obstetric patients who had low positive APL. And this is what we found, that if you don't do anticardiolipin antibodies, you'll miss about 10%. And if you don't do anti-beta-2-GP1, you'll miss about 13% of patients. And clearly, these percentages will vary depending on the population you're studying. The other thing is that I would say that one needs to test for both IgG and IgM antibodies. These were defined in the Sapporo criteria, which clearly were criteria for scientific studies rather than from clinical use. However, there has been a recent publication by Katrin de Vries's group where they looked at 177 studies out of a total of over 2,000. And what they found was that while IgG is and was more clearly associated with thrombosis, there were patients where IgM was associated with thrombosis and IgG was not. What they didn't have for their study was sufficient paired samples, and they are pursuing this currently. So the jury is out, and we are in the process of doing an in vitro study looking at thrombogenicity of IgM. The other thing to mention is what about the non-criteria antiphospholipid antibodies, such as antiphosphatidylserine, prothrombin? We don't know. These look as though they might be important, but more work is needed. Now, what if a patient has got antiphospholipid antibodies? Here are what happens to triple positive APL patients, which is another reason for wanting to do all three antibodies. So if you look at, here are asymptomatic patients or individuals, and here they have the normal subjects. Here are single positive APL patients, and here are triple positive patients. And you can see that the cumulative incidence of thromboembolic events is much higher if you're triple positive. And the annual rates of the first cardiovascular events, 37% at 10 years. That's quite a lot. Now, what about APL triple positive patients who have already had a thrombosis? Vittorio Pengo has done this study also, and what they have is, in this study, there were 37 patients with not on oral anticoagulants who'd had a previous VTE event or arterial thrombosis, and 123 who were on anticoagulation. So a total of 160 venous and arterial patients. And what they found was that thromboembolism occurred, as you might expect, in the patients who weren't on anticoagulation, but also occurred in the patients who were on anticoagulation. This was standard intensity target INR 2 to 3. This is an interesting study from Sam Schulman's group many years ago, where they showed that anticardiolipin antibodies predict early recurrence of thromboembolism and also death. So that in this prospective study, if a patient was anticardiolipin positive, and one of the flaws was they didn't repeat it during the study, this doubled the risk of recurrent VTE, which is quite an interesting observation. So who do we test? Patients who have unprovoked proximal DVT or PE. One might ask, what is it that makes a distal DVT different? It's still a DVT. Recurrent thrombosis, young adults, in quotes, less than 50 years with ischemic stroke. In our trust, and this, by the way, is in the Royal College of Physicians guidelines on stroke, and our trust is now doing it for patients in our HASU unit up to 65. And then obstetric indications, these are a la the Miakis criteria. However, in addition to the Miakis criteria, there are non-criteria manifestations of obstetric APS. And we, our group, and you can see Deepa Rachlaj, who's sitting in the audience here, put together this review. And these are patients who don't fulfill the exact criteria set in the Sapporo-Sydney criteria. But the key point here is that if you look at these patients in prospective and retrospective cohort studies, they seem to do as well as the standard patients who have got obstetric APS. And that's important. We haven't got RCTs, but there are prospective cohort data. And just to remind us all, this is what we do currently with recurrent miscarriage patients. We did the first of these studies with Leslie Regan way back to show that aspirin plus low, at that time we used unfractionated heparin, is better than aspirin alone. And nevertheless, even with that treatment, patients still were having premature deliveries in about 1/4 of them. And this is just to draw your attention to Hypatia, which is a study being led by Beverly Hunt, looking at hydroxychloroquine to improve pregnancy outcome. And this is going to be an RCT placebo-controlled. And this is starting up currently. So we'll see. Hydroxychloroquine is an interesting drug. It has various hemostatic effects. It encourages hemostasis. For example, it will protect the annexin 5 shield from disruption by antiphospholipid antibodies. This is important to look at. These are data from Jean-Christophe Guy's group, where they've done a lot of work on miscarriage patients. And what they have done is that they followed up these patients years on, and the groups are patients with recurrent miscarriage who have antiphospholipid antibodies. That's the green. And you can see that they have more VTE as the years go on than do miscarriage patients who have constitutional thrombophilia, and this was factor V Leiden heterozygosity or of the prothrombin gene mutation, compared with negative women. So that's quite interesting. So these patients with obstetric APS need to be watched lifelong in terms of thrombosis prevention. So this is what is happening in a very Mickey Mouse way in antiphospholipid syndrome. Basically, we get upregulation of hemostasis, we get a prothrombotic phenotype, and it's worth iterating this, that individual risk factors do play a role, and therefore I always tell the GPs, actively manage cardiovascular risk factors. That makes a lot of sense. And then obviously, in prothrombotic situations, patients need to be warned that they do need to take risk reduction measures. This I'm not going to go through, but this is simply showing all the many pathways that can lead to upregulation of hemostasis. And if you're interested to read about it, this is a chapter of over 100 pages, I have to tell you, in a book which is the Proceedings of the International APS Congress that was held in North Cyprus towards the end of 2016. So this is out there. Now, what about the first VTE? So if a patient with APS has got a venous thromboembolic episode, of course we don't always know they have when they come along with their VTE. But what do? If it's unprovoked, it's easy. You consider long-term anticoagulation. You might say you're going to do that anyway. However, if they've got APS, particularly if they're a woman and they don't need to wear a black dress, what happens is that they will, if they're going to get pregnant, need different management to a normal VT patient when they get pregnant. Because for one thing, they should have aspirin. For another thing, they need careful fetal monitoring because there may be fetal growth restriction, which would necessitate earlier delivery, for example. Now, what about if they have a transient risk factor? Limited duration anticoagulation, that's pretty standard. And David Keeling sitting here, and that's from the BSH guidelines, and also from the task force of the International Congress on APL from a number of years ago, admittedly. However, we do see patients where you might say the risk or the event is slightly disproportionate to the trigger. And I think we need to therefore individualize how we're managing these patients and think about whether we should measure antiphospholipid antibodies in such patients. Because there is no study that tells us that patients with transient risk factors who have antiphospholipid antibodies do not need anticoagulation long term. We don't know that study, it doesn't exist. So that would be a study to do, but it hasn't been done yet. So in the meantime, I think individualization. Now, what about stroke? What should we use in terms of anticoagulation intensity? I should say there's also debate as to whether they need anticoagulation at all. But let's start from anticoagulation. So these are the two key studies in this area, the Finazzi and Crowther RCTs, which were actually published in the sort of early mid-2000s. And this just reflects just how poor we are with regard to studies in APS. The first thing to say is that across both studies, there was only 71 patients in total with arterial thrombosis, and not all of them had stroke. And we know that in the Crowther study, that 6 of the 8 patients who had recurrent thrombosis had subtherapeutic INRs at the time, and one of them had been off warfarin for more than 100 days. So it wouldn't be surprising that he's had a recurrent event. In the Fenazzi study, there was no data about what their INRs were at the time of the event. The WARS APAS study, which was the APAS study, was a nested study within WARS, had really quite questionable laboratory criteria. In this study, what they did is they took patients with stroke and they randomized them to be given aspirin at a dose of over 300 milligrams a day versus warfarin at a rather strange INR target of 1.4 to 2.8. Then there was a meta-analysis of 16 studies, which actually yielded some quite interesting data. 3/4 of the 180 patients who got recurrent thrombosis in this, or got thrombosis in this study, had not been on anticoagulation. So they'd had their event, then they weren't on anticoagulation, or they were on aspirin. Of the remainder that were left, that was 49 patients left, only 7 had a recurrent clot when their INR was above 3. And then here we have also, harking back to the triple positive data from Vittorio Pengo, that approximately 50% of the patients who clotted on an INR of 2 to 3 actually had arterial thrombosis. So now, what do we do if a patient has refractory thrombosis? The first thing is obviously to go through the usual stuff of whether or not the patient is adherent to their treatment, for example, whether their INRs are difficult to control and they're mainly running therapeutic. And then we need to consider the possibility that the INR may not actually reflect the true anticoagulant intensity in this patient because of the variable sensitivity of lupus anticoagulant to the thromboplastins. Now, in a teaching type hospital laboratory or hospital laboratory where there is interest in hemostasis, it should be fine to work this out in the laboratory, but there will be places where it might not be quite so easy. And so we should consider doing an amidolytic factor 10, and there are ranges, approximate ranges, but there are ranges so you can at least get a rough idea. If the patients are on standard intensity warfarin, target 2 to 3, then obviously one would increase. I say obviously, but where's the trial data? There isn't any. But I would say this one is the parachute test. If you jump out without your parachute, there's only one thing that will happen. So I think that's okay to do. Now, what about low molecular weight heparin? When patients fail on warfarin, we tend to give them low molecular weight heparin as a first up, and we can debate which dose we use, whether we use a standard dose or whether we use a high-intensity dose, and I think that needs to be individualized. However, patients don't always respond to that. And then and by now we are really in Never Never Land because this is all based on anecdotal stuff, small studies. Fondaparinux, I have 2 patients on fondaparinux, one on fondaparinux plus clopidogrel, and they've both remained clot-free, having had major recurrent events until then, and we're now sort of 2 years out for both of them. And antiplatelet agents can be adjunctive, but this is all very anecdotal stuff. And then, of course, there's further adjunctive treatments. Hydroxychloroquine, we've mentioned earlier, I think might be useful. Statins, the data do not support just giving statins, but simply giving them should the patient have a high cholesterol. But statins also have been shown, fluvastatin in a study, to actually downregulate pro-inflammatory and procoagulant markers. We use rituximab, rituximab in the wrong place. We use rituximab in patients who just don't do on standard anticoagulation treatment. And then, of course, we're into the really anecdotal stuff. Here's what other things one can do. So this patient had recurrent VTE, and his INR was set by my predecessor, actually, between 5 and 7 plus aspirin. In fact, it's not really 5 to 7, because when we do the amidolytic and factor 10, it comes out as being lower than you'd expect. But that's his range, and he also has step and fragment. but he needed a pulmonary thrombectomy, so that's another maneuver that can be done. This lady is one of the ones who is now on fondaparinux and clopidogrel. She had multiple clots, 2 cerebral venous sinus thromboses, then cerebral infarction on fragment, then extensive pulmonary embolism requiring a VATS procedure. And at that stage, because she was properly anticoagulated, she had an IVC filter. She then blocked from the filter down to the tips of her toes, had incipient gangrene, and she, you can't see any, this total blockage all the way up to the iliac IVC filter. And what she had was catheter-directed thrombolysis, which opened up her veins. She then subsequently went on to have some further clots. She clotted her renal vein. They couldn't get out the filter, so they had to flatten it against the side of the walls. And eventually she had stents put in the IVC and the common iliacs. And then she was doing really well until I went on holiday. And she texted me and said, "I'll give you the heads up." She'd taken a break from her treatment. And she only told the porter when they were wheeling her off to the CDT lab. So this lady came with, in fact, it was a blue toe, and it progressed to that. She has a background of SLE, and this was shown to be due to microvascular thrombosis. And this was very refractory to treatment. As you can imagine, we gave her everything we could. It was slightly complicated by the fact her platelets were also low. And eventually she had an epidermal graft, which is just single layer graft, which seems to have helped. I'm going to, and that's the ulcer there, which is better. Now I'm going to say something about DOACs. So the jury's out currently. We did the RAPS trial. And why did we do this? We did it because we know that 10% of VTE patients may have antiphospholipid antibodies, but in the big trials from the manufacturers on the DOACs, we didn't know who these patients were. The other thing is, could antiphospholipid antibodies interfere with the anticoagulant action of DOACs? And the answer to that question was provided in work that Deepa Rachalaj did to say no. So the primary outcome was the percentage change in the endogenous thrombin potential. And here's the ETPs. These dotted lines are the normal ranges. And the warfarin patients had a greater ETP than did the patients on rivaroxaban. However, peak thrombin was lower in the was higher in the lower in the warfarin patients. And this is what we think the explanation is. So here are the RAPS thrombin generation curves. And with warfarin, this is normal, this blue one here, you get a sharp peak and a short tail. But with rivaroxaban, this is the normal up here again, what you get is it just goes on and on and on. You get a very protracted thrombin generation curve. And we believe the reason for that is that because warfarin inhibits the vitamin K dependent factors, it affects all phases of the thrombin generation test. Whereas with rivaroxaban as a direct anti-10A inhibitor, it is interfering with the initiation and propagation of clotting and the formation of the prothrombinase complex. And so we concluded that, therefore, overall, the thrombin generation test did not show any increased risk, and the patients, none of them had thrombosis through this period, and in addition, coagulation activation markers were raised in very few patients in both groups. There was also improved quality of life in the rivaroxaban patients. The other DOAC studies currently going on are TRAPS, where they have so far accrued 113 out of 536 patients. are extending the trial out to Eastern Europe. ASTRO-APS was stopped twice by the time they got to 25 patients, and now has adopted a RAPS protocol and has restarted the trial. And then the RAPS phase 4 study, not trial, had to stop before they recruited all the patients they could, and they are doing fine, apparently. This slide is just to show you that the patients on DOACs from the anecdotal literature, the ones who have VTE, single event, or require an INR of 2 to 3, they seem to be okay. The ones who have had arterial thrombosis or microvascular thrombosis, they don't seem to be okay in the main. Sometimes they are, but not always. This is on standard intensity. This is just to draw your attention to the fact, looking at C5a complement activation marker level on, in patients in the RAPS trial, we found that rivaroxaban actually decreases a complement activation. And here you can see the individual levels in the warfarin and the rivaroxaban patients. Quite convincingly, you can see that it goes down. So this may be an adjunctive effect of rivaroxaban. Finally, I will just mention that we are now about to start up the RISAPS trial, that there are some people in this audience, Rupin being one, Deepa being another, who are co-investigators. And this is looking at rivaroxaban in stroke patients with APS. And so I would say to end my talk, acknowledge all the people who have been involved, and also to say we need more trials in APS. Thank you.